So, how do we prescribe antibiotic prophylaxis? That is actually a very good question because most people don't understand why they prescribe and what they prescribe before surgery. Today, we're going to answer that question by understanding what it's for and how to do it. Let's get started. We have to understand the different types of wound classification. There's actually 4 types of wound classification. Number 1, it's a clean wound if there's no evidence of infection. Specific examples are hernia surgery, those with no previous infections, those with no entry into the gut. Other examples are excision of soft tissue mass. The second type is class number 2. And class 2 is basically when you have enter of a hollow viscous organ. This is a controlled entry. You don't spill anything. So doing an elective cholecystectomy falls under class 2. However, if it does have cholecystitis, that has some form of inflammation, and that makes it a class 3. That differentiates a class 2 from a class 3 if there's inflammation or if there is any active infection. What then is a class 4, which is a dirty wound? So we have class 1 is clean, class 2 is clean contaminated, class 3 is contaminated, and class 4 is dirty. Well, dirty is somebody who had a hollow viscous organ perforation with either pus or stool inside their belly. And so that is basically a contaminated field. And compared to a contaminated, which is acute cholecystitis, or if you have any spillage, that's a whole different animal or ballgame in which you have a higher risk of infection. So let's go to the risk of infection that actually makes a significant difference. So for the first one, which is clean, the risk is between 1 to 5%, so it's quite low. Class 2, which is clean contaminated, is between 5 to 10%. The third one is between 10 to 20%, which is for contaminated wounds. And for dirty wounds, it's more than 20%. Some actually code as high as 40%. And given that aspect, you also have to understand the types of infection when we talk about surgical site infection. There's going to be superficial, there's going to be a deep, and an organ space. What's the difference? Well, superficial is you have an infection over your skin and it goes all the way down to your subcutaneous tissue. But when it goes deeper down into your muscle or subfascial area, then that becomes a deep surgical site infection. But what's the difference between an organ space infection and a deep surgical site infection? Well, an organ space is if you did surgery, let's say for diverticulitis, and now you have an intra-abdominal abscess, that is an organ space. It is no longer in the abdominal wall, but it is in the peritoneal cavity. If you have a drain inside and it turns into pus, that's an organ space infection. If you have an infection deep within the muscle only, then that's a deep space. So we have superficial, we have deep, and we have organ space. Now let's add them all up together. So we talked about wound classes, we talked about types of infection and risk of infection per wound class. Where does antibiotics actually come in? Well, we want to decrease the risk of those bad things happening when we actually prescribe antibiotics. But who needs them? Most of class 1 wounds, because they're clean, won't need any antibiotics. If you're doing a soft tissue mass excision, they won't need any antibiotics. But who would need them? Well, to decrease risk of infection anytime we actually implant a foreign body, we would prefer to provide antibiotics in that aspect. Class 2 to 4 are commonly the ones who actually need more antibiotics. And so this is now given to expect the type of organisms that you want to cover. In general, if you look at foregut to your hindgut, you may have more gram-positives in your foregut, and as you go towards your biliary, towards your hindgut, there would be more gram-negative until you're towards your colon, in which you have more anaerobes. So if you're tailoring your antibiotic prophylaxis, you may consider things that cover gram-positive when you're doing foregut versus considering more gram-negative coverage. What are examples of gram-positives for coverage? Well, you can use beta-lactam. You could use Ansef for as an example, which is a first-generation cephalosporin. For gram-negative coverage, you may opt to choose a third-generation cephalosporin, which is going to be your ceftriaxone. Other examples, you could consider using Levaquin, which is a fluoroquinolone, and other examples could be carbapenims, which is your imipenem or meropenem. Those big guns are seldom used because you don't want resistance to occur, so you have to be cautious about it. But there are so many antibiotics to choose from. How do we know? Well, let's look at the guidelines. You would have a first line of treatment for coverage for your antibiotic prophylaxis, which would mostly be your first-generation cephalosporin most of the time for the surgeries that we perform. When do we change it? Number one, if they have allergy, which is significant to beta-lactams or penicillin, or specifically for cephalosporins. Number two, if they have had a previous culture of a different type of organism. Let's say we're expecting gram-positive coverage, but they actually had Pseudomonas and we're doing a ventral hernia repair. Well, number one, we want to make sure we have eradication of Pseudomonas specifically. And number two, we want to make sure that that antibiotic coverage is provided to cover Pseudomonas specifically in that type of surgery because the patient had a history. For people, those who had a history, and those people who have allergies, those are the people whom we will change from our first line to either a second line or something specifically tailored. And from there, you want to be giving this antibiotics 30 minutes before the surgery for it to make sure it is adequate prophylaxis. I hope you guys liked the video. If you have any questions, please put them on the comments or any suggestions, and would appreciate if you hit the like and subscribe button. I'll see you guys next week.